So I mentioned some of the benefits of electronic reports. They have that ease of data collection and merging data. There's a decrease in errors. And by errors, I think it's a lot of it's really omissions. So the omissions are many fewer because you can set, for example, this little thing over here says chief complaint. You can set these programs to say you can't finish this report unless you enter a chief complaint, which means that you have to come in and pick one of these things before you can even complete the report. So it decreases the errors, I think, largely in part due to the decrease in omissions. Some of the obstacles, though, are cost, and in some cases the technology can be unreliable, though these systems have existed for long enough now that the technology is reasonably reliable. So every call you go on, you'll write documentation. Your PCR should contain subjective information, so this is basically your patient's story. Everything they tell you that you feel is pertinent. Objective observations, so what have you seen? What did you assess on your patient and what did you find from that assessment? And this is all objective. Treatments, anything that you did for your patient, the effects of those treatments, and any changes in your patient's condition. You can also see right here, there's a space for vital signs. So we'll make sure to document at least 2 sets of vital signs on your patients. A good medical record is accurate. You want to document facts and observations only. This is actually more difficult than it sounds, and we're going to practice this in class. You may want to document something, maybe you have a patient who's upset. She's telling you that her boyfriend just dumped her, and she's crying, and she's hyperventilating, right? So maybe her respiratory rate is 40. There's a hint that's high. And you're trying to figure out a way to document it without saying patient is upset. So what you want to say, because upset is a judge word, right? You've basically made a conclusion based on what you've seen. You are not allowed to make those conclusions in your report. You have to document patient is crying, because that's an observation, right? Patient is crying. And then you can say patient states that her boyfriend just dumped her. From that information, most readers will understand that the reason that she is breathing this fast, well, you may have to draw a few more connections, but basically the reason that she's breathing this fast is because she's crying and upset. So we can't say patient's upset and hyperventilating. We can say that she's crying, she says that her boyfriend dumped her, and that she's not having any difficulty breathing. That sort of stuff is what we can put in our report. So we'll get some practice with that. It's a little more difficult than it seems. So we also want to double check any numerical entries, make sure we haven't typed anything in wrong or written anything wrong. Recheck spellings. If you're on a computer, which most of them are, they all have spell check. Be sure to use it. If you make an error and you haven't, it's not one that you can just kind of go back and fix in the computer, then you need to make a note of it. You need to document it. And I guess this probably means make a patient care error. It's okay. You still have to document it. You're not going to document, something you didn't do because that would be inappropriate. You have to document what you did, even if you made a mistake. So a good medical record is complete. If there are boxes to fill in, then fill them in. Try and include at least 2 sets of vital signs on every patient. So failure to document basically means failure to investigate. Always document your pertinent negatives. So one of the things that I'll teach you guys about is a patient who has chest pain. I like to use chest pain because there's always a lot of questions to ask chest pain patients. One of the things that you should ask about is, do you have any associated shortness of breath? Yes, we use SOB as abbreviation for shortness of breath. Just go with it. So any shortness of breath. Do you have any nausea or vomiting? And you have to document that they didn't have any. So you have to document your pertinent negatives as well. If it wasn't documented, it wasn't done. And the question here is, can you remember what you did 2 years ago? How about 5 years ago or 7 years ago? It may take this long for a court case involving your patient to actually make it to court. So it's important for you to have a good, thorough document. Good medical record is legible. Documents presented in course must speak for themselves. So basically, they're going to take your document and put it up on a big projector for the entire world to see, and it needs to speak for itself. You'll be there to answer a few questions, but basically the jury should understand it with some kind of exceptions for particular medical terms. The people in the courtroom should understand it. A sloppy report, you can guarantee that the defendant's attorney is going to tear your record apart. If you have a sloppy record, they're going to suggest that your care was sloppy, and if it's a negligence claim, the defendant's probably going to win. Recheck your spellings. Poor spelling looks bad when you go to court. And if the document can't be deciphered, a jury may ignore it altogether. A good medical record is free of extraneous information. You don't have to put in that the patient was wearing a red shirt and blue jeans, unless that is somehow, for whatever reason, pertinent to your patient's care. But what they're wearing, what their family member ate for breakfast is not pertinent. So it needs to be pertinent to your patient. Avoid labeling the patient. For example, drunk. Unless you watch the patient consume 30 beers, or however many beers they're telling you, you document things like they have the odor of alcohol, which we abbreviate ETOH for ethanoic acid, or sorry, not ethanoic acid, for ethanol, for ethyl alcohol. That's a fancy abbreviation for alcohol that people drink. So you document odor of alcohol on or about the patient, because that doesn't say that they necessarily consumed it. It's just saying that there's an odor of alcohol and it got stronger when you got to the patient. You can document the patient has an unsteady gait. And that means that when they try to walk, they're kind of all over the place. You can document that they have dilated pupils. And you can document that they have slurred speech. So that's a way to get around drunk. So odor of alcohol on or about the patient with an unsteady gait, dilated pupils, and slurred speech, that pretty much says drunk. But if you take it to court, this is defensible. You can defend this. You cannot defend drunk. You want to preface any statements you have, either per the witness or per the patient, or I always use, because it's faster to write, patient states, and then quotes, whatever they said. Or bystander, or whoever the bystander is, patient's mom states. Record hearsay only if it's applicable. Patient's mom states that she saw a patient doing drugs this morning. Don't record it as fact. So if the patient's mom tells you the patient was doing drugs this morning, then you don't say that patient was doing drugs this morning, because you can't verify it. You have to write that patient's mom said patient's doing drugs. Humor has no place in the report. Absolutely not. It may be that sometimes your patients say things that are pertinent that come across as funny, and if you put those word for word in quotes, it's okay, but reports are not supposed to be funny. This is not funny business, and if your report goes to court, then you're going to get torn apart by the jury for having a funny report.